But one thing I've never been able to come to terms with is systems that we create fail patients regularly, and that we can do something to change those systems. I joke that I went to too many meetings until I started to run the meetings and ended up in my role as a chief medical officer of the state. But I really came in to think about how systems could be changed to better serve patients. And I really think we can decrease cost of care, improve health overall, improve wellness. And I think that helps our economy. It helps our national security.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. The purpose of this podcast is to tell the stories of Alaskans of interest and importance. Today, our guest is Dr. Ann Zink, who served as the Chief Medical Officer for the state of Alaska and Governor Dunleavy's administration from 2019 until the spring of this year. She is a practicing emergency room physician who served as the Emergency Department Medical Director of the Mat-Su Regional Medical Center from 2010 till 2018. She received her medical degree from Stanford University School of Medicine and completed her residency at the University of Utah. Dr. Ann Zink, welcome to the podcast.
It's great to be here.
I went down a little rabbit hole researching for this interview this morning.
Okay.
I watched some YouTube videos of your grandfather.
Yeah.
Albert Bartlett was a physicist at the University of Colorado Boulder.
Yep.
And he's famous.
Yeah. We used to tease him that he was the most famous person in our family, and he was well known. I think primarily he became well known because he was a very good teacher. He was really good at explaining complex physics principles in really colorful, basic, easy to understand ways. So he taught most of the intro physics courses at CU for years. And in fact, the Intro to Physics Lecture Hall is named after him now.
I'm going to drop a link to his most famous YouTube video in the show notes.
Okay.
It's about exponential growth. I think one of the best examples he uses is the price of a ski lift ticket. Here's a clip of Ann Zink's grandfather, Albert Bartlett, lecturing in the 1990s. This clip has over 5 million views. It is him explaining what 7% growth per year does to the price of a ski lift ticket. But he'll be referring to some figures on the board, and so I'm going to read those figures for you.
Now, do you know what 7% really means? Let's take another example from Colorado. The cost of an all-day lift ticket to ski at Vail has been growing about 7% per year ever since Vail first opened in 1963, and at that time you paid $5 for an all-day lift ticket. Now, what's the doubling time for 7% growth? 10 years. So what was the cost 10 years later in 1973?
$10.
10 years later in 1983.
$20.
10 years later in 1993.
$40.
And what do we have to look forward to?
2003 would be $80. 2013 would be $160. 2023 would be $320.
Now, this is what 7% means. Most people don't have a clue.
According to Vail.com, if you purchased a Vail lift ticket in advance, it would cost $295 for an all-day adult lift ticket. So if you bought it at the window, it would be around $320 or more. So he was right on, just showing that what sounds like quote-unquote stable growth at 7% per year actually is exponential growth.
Yeah, he was really good at explaining particularly challenging physics and math concepts. I got asked early on in the pandemic if I thought about him. And one, he's my grandfather. Yes, I think about him and all of my family members on a regular basis. I was really fortunate to grow up with a really dynamic, interesting family. I thought about him a lot early on because we were talking a lot about exponential growth and what an R naught of 2 meant, or an R naught of 2.8, which is very similar to an interest rate, like at how things can grow exponentially. And so his ability to explain how things grew exponentially were really important. The other thing that I thought a lot about during the pandemic was he always said that his role was to bring awareness to numbers and to explain them. But his goal was never to create policy or policy change. And I have these very vivid memories of sitting on his living room floor as a kid and challenging him and saying, you can't just bring up problems and not come up with solutions. Like, what is your solution, Grandpa? You're just like talking about like these really catastrophic things. And he would say, that's not my job to figure it out.
He called one group of mathematics the flat earthers. That's in his Wikipedia article. He did say some controversial things, and he definitely made some news in terms of judging folks I think, who thought that there was such a thing as sustainable growth.
Yeah.
So he definitely had a position
Yeah.
that would inform policymakers.
Yeah, I agree with you. And I remember even as a kid, honestly being frustrated by that and saying, you can't wash your hands of this and saying that you aren't having policy recommendations. You are in the way that you are stating these. And so what does that really look like?
Let's just be explicit, if
Yeah.
it's okay.
Yeah.
So your grandfather believed that there was no such thing as sustainable growth of the human population.
Yeah.
That the human population growing at a quote unquote sustainable rate would be doubling every certain number of years, and that would result in too many humans,
Yeah.
and we would run out of resources.
Yeah.
That we absolutely cannot have enough energy, enough food, enough, you name it, to sustain an exponential growth of the human population.
Yeah.
That is proved to be an issue for you, like that little piece of his biography.
For sure, it's proved to be a huge issue for me because people then interpreted that as that I was not there to promote the health and well-being of Alaskans, which was 100% and continues to be my focus and place of advocacy and work. And so that got taken out of context in many ways. Everything from thinking that vaccines were meant to harm people instead of the data and science really showing that they really decrease significant risk of hospitalization and death. And so that context got taken out. We all have family members and they are all different and unique individuals in and of themselves. And so we may think of and love people in our family who we have different perspectives from and different ideas from. And I really always admired my grandfather's ability to talk about science, to talk about issues. He was very loving. He came up and hung out with my kids all the time. I remember when he was becoming elderly, he got into his 90s. I remember he was starting to struggle with incontinence, and I had a little tiny kid who was also learning to not use a diaper. And he had this sweet, lovely conversation with her about how it's okay to make mistakes sometimes and have accidents. And we're both going to figure it out together. And it was so sweet between this 3-year-old and 9-year-old. So those are the parts of my grandfather that I remember and love and cherish. And I think his ability to explain things clearly was something I love. His policy statements and the ways that he thought about the solutions were very different than even mine as a young kid and mine now. And I think we came to many areas of agreement, such as education being a critical tool into being able to understand everything from exponential growth to being able to understand limited finite resources and the ways that we make the best decisions we can as humans. So we both really leaned into how education was incredibly important. And that was a common ground that we had in that space.
So you grew up in Colorado.
Yep.
Your grandfather was part of your life.
Yeah.
He was in Colorado, obviously.
Yep.
What about your paternal grandparents? Were they in Colorado as well?
So they were. Yeah. My mom, who is the grandfather we're speaking about, is my mom's father. And they came out to Colorado basically for him to teach physics out at CU. And she was the oldest of 4. She went into medicine, and that was her world. And
What kind of doctor?
She's an OBGYN. And so she practiced for years. She was one of the first women physicians in her class. And then she was one of the first female OBGYNs. She was one of the first women to climb Mount Logan. So she actually hitchhiked up to Alaska right out of college and had come up here. So that was where my interest and fascination in Alaska initially started. And she met my father in med school. My father grew up the eldest of 7, the son of a barber and a waitress. He had been born in Minnesota, but he had such bad asthma that he spent most of his summers either in the house or in the hospital. And when he was young, just about first grade, his doctor said they either needed to move either to Colorado or to Maine, or he would die. And so his family had no money, no other support structures in either of those places, and packed up everything that they knew and had to go to Colorado so that my father would have a chance to live. And I think to his deathbed, he carried a lot of guilt of that loss and that leaving. He was a smart kid who played hockey, and the Ivy League schools were recruiting hockey players who had good SAT scores. And so the next thing he knew, he was at the University of Pennsylvania, had never been to a city before, had never met a Black person before, and was there in the 60s. And
so he grew up in rural Colorado.
He grew up in rural Colorado, rural outside Colorado Springs, Colorado. And he got to Philadelphia, absolutely loved it, just blew his mind. It was a whole other world. He was an econ major. But he got sick his senior year and really realized that he could do a lot in medicine. So he decided to go to medical school as well. And that's where he and my mom met, was in medical school. And he became an oncologist. And he worked for the VA hospital system for most of my life. He did a fellowship in New York City. So we lived there for 3 years when I was little. But then for the rest of his life, he worked at the VA. And serving veterans was his absolute greatest joy. He really deeply believed in community service and serving one's community. Huge admiration for military. He could not serve in the Vietnam War because his asthma was so bad, but he lost many of his classmates and friends. And I think he felt an obligation to serve the country in a way he could. And he did that by being a doctor of the VA system. So I grew up kid of two doctors, OBGYN and oncology, promised myself I'd never become a physician, and here I am.
According to one article that I read, your mother never suggested that you become a physician until you were on a hiking trip with some other teenagers when you were 15. Your friend fell, his toes got ripped off.
Yeah, both of my parents were actually really great about never pushing me into medicine. They said, you do what you want to do. I was involved in a hiking trip when I was 15, and a kid fell down the boulder field, and his toes were amputated in that experience.
Fourth and fifth?
It was his second and third toe that he lost in that process. And it was, 15 years old, and we were stuck out there for a couple days in a snowstorm and trying to figure out how to get him out. And it was an eye-opening experience. That was in high school. I still wasn't super interested in medicine. I went to college. I was an inorganic chemistry major and fine arts minor. Wasn't thinking I was going to go into medicine. I was really interested in, like my grandfather, teaching. I was also really interested in how chemistry could be used to better explain the world, to create new materials that could be used really effectively. I worked in a molybdenum lab that was used for oil cleanup, and it was fascinating. But I wasn't sure what I wanted to do. My dean in college had recommended that I apply for this fellowship called the Watson Fellowship. So I applied for that, and that provided support for me to travel for a year. And I was very interested in how location and place impact one's overall well-being. So I was looking at the impact of tourism on culture and environment in Nepal, Antarctica, and Botswana. And it was through that experience that I kept realizing that health was just a key component of everything we do. And if we don't have health, we don't have anything. And that healthy economies are built with healthy people. And so I kept finding myself trying to think about how to improve systems of care and ending up in health clinics as a way to really get to the heart of what made people well and to what make economies survive. And that was in that year is when I decided that medicine is really where I wanted to go.
And you ended up going to medical school. So
Yep. It was really on that year. I kept finding myself in different situations regarding health. So in Nepal, I found myself in a health clinic doing high altitude work. I found myself in Tibet doing health work. I found myself in Botswana, really fascinated on how the social structure of where people lived and work really depended on their HIV treatment. So a community that I worked in and a tourism organization that I worked with, the way that they were able to administer HIV medication to really decrease the rates of HIV, particularly maternal HIV, how important was it to understand people in the context in which they live and work was super fascinating to me. And I found that medicine gave me this opportunity to provide this connection between the science and the data and the people and the place and the practice. And I really love that art of medicine. I think that was something that was hard to explain to the public during COVID, continues to be hard to explain to my patients, is that there's lots we don't know. And it is this art of trying to know as much as we can about the way that the body works, the way that medicines interact, the way that we as society interact, and that individual person or that community's health. And I just found myself constantly ending up in those situations and realized that despite my rebellion from my parents, that was my true love. And that's where I would be best served.
You mentioned your mom coming up to Alaska when she was young.
Mm-hmm.
You had Alaska somewhere in your subconscious. What ultimately brought you and your family to Alaska?
Yeah, I think it was probably my subconscious from those things. In college, became a mountaineering guide. And so my first time to Alaska was my junior year of college. I was working for NOLS, the National Outdoor Leadership School. I'd worked in Wyoming for a year, and then I got a job working in Alaska that next summer. So I flew up to Alaska, and my very first day in Alaska was backcountry skiing in Hatcher's Pass. My second day was backcountry skiing in Turnagain Arm, and my third day in Alaska was flying into the Matanuska Glacier and seeing a huge grizzly on the way out there. And I was pretty sold after those 3 days and was just fascinated by the land. But I quickly started to just really fall in love with the people. And then I ended up falling in love with a person who was also working up here. And so after I finished...
Oh, so your husband was already here.
My husband was also a mountaineering guide.
Oh,
so
gotcha.
we both were guiding up here.
Gotcha.
And so we started to date. I then decided I wanted to go to med school. We went to med school in California. I went to residency in Utah.
Is your husband a doctor?
No, my husband's not a doctor. No,
What's he do?
definitely not. That's a great question. He keeps our life together. He does real estate. He did mountaineering for years, and he is the jack of all trades who keeps all of the balls in the air in our family.
Oh, that totally makes sense.
Yeah.
One of the things that I thought a lot about when, again, doing research for the interview, was you having to be on Zoom calls at 4 a.m., I guess East Coast time stuff, working shifts in the ER, being the chief medical officer for the state of Alaska. And I was like, oh my God, who's like picking kids up? You know what I mean? Somebody has
Yeah.
to like have the flexibility to be able to make the household run.
Yeah, and that was 100% him. He's been amazing in that way. He's also had his own career, interests, and passions, but I feel very fortunate that he's been able to be as flexible as he's been. And then, honestly, I adore my kiddos. They're freaking awesome. And during COVID particularly, they took a brunt of a lot of my time away from them and work, and that was not easy on them. And they really rose to the occasion. Okay.
So you started working at Matsu Regional in the ER.
Yep.
But it seems like pretty quickly you became the director of the ER.
Yeah. No, you've done a great job on your research. Yeah. So I came up here right out of residency. My husband was really interested in moving back to Alaska. Med school and residency weren't easy, and I don't think they're any easy for anyone, but I had my oldest daughter as a third-year med student and my youngest daughter as a second-year resident. So by the time we finished residency, we had 2 small kids and just a lot going on in our lives.
I can't even imagine. I'm not sure listeners can understand that as a resident in the ER, you have the worst schedule imaginable, just torturous. And you had babies. I can't even imagine. It just seems like the worst.
And it was definitely challenging in many ways. A reason that people call them house residents is because you resided in the hospital. That was like where the term came from. I think it has gotten a bit better over time. When I was the first person in my residency class to have a child during residency, I was the first woman to have a child during residency. I had one attending who was female who had kids. And we got 3 weeks of vacation a year. I had used 1 week of vacation. And so my other 2 weeks were my 2 weeks of maternity leave. I had 2 weeks essentially of that time. I was fortunate that I was healthy. I was fortunate that I had healthy pregnancies. I was fortunate that I had a husband who was flexible and could be super supportive of that. So I don't recommend that to people, but I had a lot of things going for me that made that more doable. I also had an attending once say to me that when kids are little, they need to be loved. And when they're older, they need you. And that really struck me. I also think the way that we do medical training in this country between the 4 years of college and then med school and then residency, which is different than a lot of other countries. As a woman, you may be really getting into high risk pregnancy time by the time you're done with all of that. Mm-hmm. And I know so many friends who are my age now and are really struggling and really want to have kids and are struggling with IVF. And I knew that having a family was a top priority for myself and my husband. And so we knew there was no perfect time, but we're grateful that we had a healthy family.
If you had waited, the young doctors in the ER, the new doctors in the ER, end up working tons anyway. It's just an expectation that the newer, younger ER docs are going to work a very full-time schedule. So it's not necessarily true that you would have had a much easier schedule if you'd waited to your first couple of years of work.
Having kids is the greatest joy of my entire life, but it is always a challenge.
Yeah.
Like it is never a great time and it's never easy in that space. And I think having community, having family, I learned in that experience about making sure that my values and priorities as a mom and as a wife came first. And I needed to make sure that no one else was going to advocate for those things. And I needed to. On the other hand, it is such an honor to care for patients. And so I needed to make sure that I have the support and resources so that when I'm caring for my patients, I'm able to fully care for my patients when I'm there. And I feel really fortunate to have lived in both of those worlds. I think we have this expectation that people can do everything, and we can't do everything. We all have limitations. People often ask me how I balance it all, and I say it's oftentimes like tree pose. You're just trying not to fall over any one direction at any one time, but you never feel solidly in the center. You always feel like you're tipping one way or the other.
Back to the ER.
Yeah.
You became the director pretty soon.
Yeah.
How and why did that come about? And was it something that you were looking for, or was it no one else wanted to do it?
You'd have to ask the people who asked me to partner exactly why they did it. But 6 months after I came up here, I was just out of residency. I was getting my feet underneath me. And my group called and said, hey, we're really interested in having you be the medical director. I was not partner with my group yet. And so I had a lot of questions like, what does this mean? What does this look like? Help me understand. Why do you want me to do this? And they're like, we think you'd be really good at it. I tend to be a yes and person, not a no person. My first initial response is yes, and I'll figure it out. I had this experience with my husband early on where we went into this climb and the climb looked completely impossible. And he said, you always have to show up for the climb. Let's not make the decision from the comfort of our bed or the discomfort of the approach. Let's make the decision from the base of the climb and then see what the weather looks like. And that was a really poignant turning moment for me of saying, let me show up for the climb and I can always make the decision that we need to not continue further or the weather's bad or we need to rappel down, but let's not make decisions from this place of discomfort or comfort of a distance. And so the medical director was a similar sort of thing. I said, I'll show up for the climb. I'll give it a shot and I'll see how it goes. And I had the honor of being the director of our medical group for 10 years. It was great. I learned a ton. The group changed a ton. The hospital changed a ton. And that was definitely not something I was looking for, but I grew a lot through that experience.
So my experience, having worked in an ER and having a medical director, or working in a couple of ERs, is that the medical director is not only like managing the providers in the ER, but they're also attending corporate meetings for the hospital and participating in a level of administration that is completely separate from the ER. And did you have any experience or know what that was going to be like? And what was that experience like?
You're exactly right. I think the medical director will manage that group, but there's a lot more to that, particularly in the emergency department. As I oftentimes say that all good public policy comes to fail in the emergency department. And suddenly it's not just how's your group doing, but it's, oh, now we have no orthopedic coverage. Like, how are we going to change that? Matsu still doesn't and has not had a chief medical officer the whole time I've been there. So there was no kind of clinical voice within the administrative role. So I oftentimes would serve that role within the hospital itself, working closely with the board. I was on the board of trustees. And then I worked closely with CHS Hospital, the hospital company that owns part of Matsu Hospital, and became very involved in everything from order sets to evidence-based practices to the way that they were working with care. And it was a fascinating experience. I learned a ton through that. I started to get involved with the hospital association. One specific example was opioids. When I trained, if you did not discharge someone home with 150 Percocets for their broken ankle, you would be written up by your attendings. They're like, no, that's what you need to do. It's insane now thinking back on it, but that was the training at that time. There was a real belief that there was no harm to these medication, that patients should be allowed to take what they feel like they need to be able to be comforted, and you should not create an extra outpatient visit if they're hurting. So you should make sure you give them enough. That was the standard. And when I moved up to Matsu and quickly over the next couple of years, it felt like you were oftentimes at odds with and in opposition to your patients because they were demanding opioids. You were seeing increasing harm from opioids. We were increasingly calling over the phone and pronouncing young people dead over and over again. It was clear we were not doing right by our patients and something needed to change. But I think it took a while for the literature to catch up, for the culture to catch up. And in that process, two people who had really struggled with opioid addiction ended up getting clean and coming to our emergency department group meeting and really clearly saying, you all did us harm. By giving us these opioids, you did us harm. And we as a group really looked internally. We worked with other stakeholders in the state. We created an opioid guidelines for the state. All the hospitals got on board. And in 1 year, we decreased the opioids out of our emergency department by 80% and increased patient satisfaction during that time. And seeing the change in the culture, but also our ability to better treat pain once we thought outside of opioids was an incredibly rewarding experience. Seeing places like my house and the Matsu Opioid Task Force, like their ability to advocate for change, working with people who had really struggled through addiction. The people that we met with years and years ago now run True North Recovery and are doing just a phenomenal job in Matsu and beyond. Fairbanks, they're working across the state in creating better systems to help patients with opioid addiction. And it has not only changed the landscape of opioid addiction and treatment options within Alaska, but I think it really gave me this belief that when we work together, we can really change systems for the better for patients. And so that would be an example of where I ended up getting involved in both state and federal legislation, as well as a lot of meetings in my role as medical director to try to change what we were doing as a hospital to serve patients better.
You also did a high utilizer program.
I did. We see a lot of patients who come in and out of the emergency department for one reason or another. Most of the time, they have complex medical and behavioral health challenges. It's not a matter of they just want to be there or they're just abusing it. They really struggle with our fractured healthcare system as a whole. And I increasingly became frustrated with feeling like I was not doing right by them. I was not helping them. I was costing the system a lot of money. If you look at the Medicaid data, about 5% of patients result in 52% of the costs. And I could directly see the names and faces of some of those patients with a lot of costs. And not only was it heartbreaking from a financial perspective, it was heartbreaking from a personal perspective and knowing that you weren't helping these patients. And so looked around the country on who was doing other things. Washington State did some really remarkable work on what they call the 7 best practices. And working with the Matsuda Health Foundation, we created an organization called HUMS, which decreases emergency department visits by somewhere between 50 to 70%, depending on the year, really by providing case coordination with individuals to help figure out the system as a whole. And sometimes it's someone with really bad anxiety who checks in and out of the emergency department because they feel like they've got chest pain. They feel like their heart is going to explode. And they end up in the mental health court who says, you need to work with this person. And they say, you got to call them before you go into the ER. And that person says, does this feel any different than it did 20 minutes ago when you were there? And they say, no, it feels the same. And they're able to help walk them through their anxiety and get treated and get better. And it's been incredibly rewarding to see patients that I have known very personally from seeing them in and out of the emergency department. And I'm at a restaurant and they're Sally the waitress, or I'm at Fred Meyer's and they're buying groceries and they tell me about how they have an apartment now and they have a job now and they have a relationship now because we were able to get to the root cause of what their visits were and help to coordinate that care, and they're able to live much more productive lives, and it costs the system a lot less money. So that was incredibly rewarding. And one of my goals at the state was to try to do more of that at the state level. There's still a lot of work to do in that space.
I think one thing that folks may not understand, again, as somebody who's worked in the ER and had the frequent flyers who come in, and I guarantee that some of these folks in their charts, if you go back and look, it's going to say over and over, advise patient to find primary care. And I think as somebody who's worked in primary care, this patient would be a quote unquote difficult patient. And we don't have enough primary care. The primary care has more than enough patients without taking on this complicated patient with mental health issues that will eat up lots of your time and be very needy. And, you know, when the ER is telling somebody, find a primary care, but primary care doesn't want that patient. People will just speak in general. Oh, we need more primary care. We need to pay more primary care. Even if you do that, there's a subset of patients that are going to have a very difficult time finding primary care.
100% agree. And the patients that oftentimes utilize the emergency department frequently, as you mentioned, have numerous reasons why they're complex. It's usually a combination, as I mentioned, physical and mental, and then oftentimes social as well. They may be homeless. They may not have transportation. They may be isolated and not have additional resources and support. So all of those things play into it. One of the things that the HUMS program does is uses community health workers, so people who have a basic training in health will go with the patient to their primary care provider office so that the primary care can say, these are the things you need to do. And then that person can help coordinate with them to take off some of that burden for primary care. We really tried to lower the burden on primary care for some of these patients. So the primary care doctor could be the primary care doctor. And then this person who would go with them would help to coordinate their transportation, their follow-up, their notes, those different things that needed to happen. Just like many people have a family member who's helping their mother care for them or other components. So that's a big part of it. There's a lot of programs nationally now who do work like this. And it's been really interesting to see the areas that they work and don't work. And we live in a really fractured healthcare system. And oftentimes we fail patients in it. And I think I came to terms with the fact that cancers happen and accidents happen and bad things happen to patients. But one thing I've never been able to come to terms with is systems that we create fail patients regularly and that we can do something to change those systems. I joke that I went to too many meetings until I started to run the meetings and ended up in my role as a chief medical officer of the state. But I really came in to think about how systems could be changed to better serve patients. And I really think we can decrease cost of care, improve health overall, improve wellness. And I think that helps our economy. It helps our national security. There's so many things that ripple effect goes through by creating better systems for people.
I'm going to do a mean pivot.
Go for it.
So the Matsu Borough Assembly passed a resolution in June that, and I may not word it absolutely correctly, but basically that was going to encourage folks to go to Alaska Regional instead of Matsu Regional, because in the quote in the article that I read was that Alaska Regional was charging 1.2 to 9.6 times less than Matsu for certain procedures, visits. And it's certainly not without controversy to tell folks in the Matsu that they need to drive 30 miles and not go to the hospital that's nearby. And I would guess that since it's the hospital that you work at, that you may not see it the same way that the Matsu Borough Assembly did when they passed this resolution. And I'm not familiar with Matsu Borough Assembly politics to know if there was other factors at play. And when we talk about like the cost of healthcare in Alaska, we don't have a lot of options. I don't know.
A couple different things. One, I was not tracking that, and it's there. I'm honestly not super surprised. The cost of healthcare in Alaska is very expensive. The cost of care in Matsu is very expensive. As I mentioned, it's complicated. What I think people don't fully always understand is that I, as a practicing emergency medicine physician, have no visibility in what the hospital charges for anything. And I don't know what they charge for an ED visit. I know what our group charges to see patients. And that is just based on essentially the Medicare, Medicaid, and the standard rates that insurances cost. So that's how we set our group rates. But I have no idea what the hospital charges as a whole. And then even with the hospital, there's what does anesthesia charge? What does ortho charge? What is like other procedures and components? One challenge that the Division of Insurance oftentimes sees is that they have no legal ability to see what those contracts look like and to see what one group's charging compared to the other. So what numbers they get in those components, I have no idea where the borough got those numbers, but the Division of Insurance can't see those contracted rates to say this one hospital's ridiculous or this one's better. And so I think if we want to even have a conversation about what contracted rates look like across hospitals, we have to have some way to be able to see what those look like. It's controversial. Insurance companies don't want you to see what they're paying or what they're negotiating down. They say those are private business practices, and providers don't want you to always see that as well. They don't want you to see what they're making or what they're contracted for X or Y, Z rate. I think if we're asking people to pay for cost of care, those are important things to see. Medicaid and Medicare rates are different. And so when a patient comes into the emergency department, our group of patients that we see, you'll have Medicaid patients, you'll have Medicare patients, you'll have private pay patients, you'll have private insurance patients, you'll have private insurance patients from out of state. You have a huge range. And in healthcare, a lot of people end up trying to figure out how to make the books work, how to figure out how to stay afloat as a practice by having a balance of those. And so you'll see a lot of primary care doctors limiting the number of Medicaid or Medicare patients that they can take because it doesn't pay at a rate that they can hire staff and that they can operate on versus something else really will. And so specifically in that Borough Assembly quote you read talks about procedures. Procedures are notorious for having a greater variability in the cost depending on location. There is also a lot of debate on if someone has the option to choose, I only want so-and-so to do it, and that's outside of my network, can I pay for that? Can I not? That individual choice and authority versus having to stay in network. And people have strong opinions about these thoughts. I will say that there's no health system in the world that's perfect. Like health systems have to deal with illness and sickness and dying and something that we inherently push against in order to live. And so we will always be in opposition in some ways to systems. However, I do think that it is a great weight on our economy. Healthcare spending is almost 19% of GDP.
Which is about double what other high-income countries spend on healthcare. And if you look population-wide, our results are not as good as some of those countries. So other countries seem to be getting better results with half the money. Yeah. So if I were to defend that Matsu Borough Assembly resolution, I would say they have one hospital, so it's a monopoly. So to encourage a competition, even though it seems, I'm not sure if my insurance is going to pay for me to go to the hospital that's nearby, why would I drive 30 miles for my insurance to pay less to this other hospital?
And it is incredibly complicated. If you're in an ATV accident at Big Lake,
You're going to go to Matsu.
EMS is only going to take you to Matsu, and you don't have a choice about that or what that looks like.
And you want to go to the closest hospital.
And you want to go to the closest hospital, and we need to find ways to make sure that doesn't bankrupt someone. And there's no Surprise Billing Act. There's other components of what that looks like, but that's a component. If I want to have my nose fixed, then I've got time and space to be able to look at different procedures and to have competition, and I've got the ability to cost price and to look at that. But there's a lot of things that fit in between those roles. Like, you need to follow up urgently. What does that mean? How urgently is urgently, and what can I afford and what can't I afford? The other thing is that you need enough volume to do certain things. So if you create so much competition that no one has an orthopedic surgeon, or I've worked in Matsu when we had 3 days of orthopedic surgery covered a month. And everything got transferred into Anchorage. Our goal is to care for patients in the Matsu Valley. That is our goal. And I tell patients all the time that if they are concerned about the costs, I want them to call our group. I want them to work with our biller. I want them to work with the hospital, because I think there's a lot more programs and aid out there that needs to happen.
Something that comes up in the ER, I'm just curious about how you navigate this. When, let's say, you're ruling out an appendicitis and it's a non-pregnant adult, we'd order a CT scan, but they ask how much that's going to cost. And the correct answer is, I don't know. And they say, I'm really worried about the cost. What I was trained is that, say, really, we want to provide you the best medical care possible right now. This is the gold standard test. We don't want you to worry about cost. That's something for another day. We want to take care of you. I'm sure I gave that speech many times early on in working at an ER, but I couldn't do that. As time went by, I couldn't say that anymore. I would say, we can probably roll it out with the ultrasound. We could probably, you can come back in 12 hours and we can repeat this abdominal exam. What are the things that I can do to delay or avoid an expensive image? What's the right answer?
I don't know if there is any right answer. I think it's why I became involved in making systems better so that patients and providers, physicians, nurses, PAs, NPs could make better decisions in collaboration with each other in lots of ways. I say something similar. I oftentimes really do a lot of shared decision making with my patients in a similar way to what you say. I oftentimes tell patients, it's not my decision to decide your priorities. I really try to not underplay the cost of care. I have patients all the time who are like, I don't want to be admitted for my heart attack. I can't afford it. I'm going to go bankrupt. I lost my house because of this other thing that happened to my family. It's the number one reason for bankruptcy in this country. And to deny that as a real factor to Alaskans is to deny a really meaningful and powerful truth. And I think that's ignoring a huge health concern for them and a financial concern that's incredibly real and I think has to be taken into consideration. So I oftentimes do shared decision-making as a combination. And I say, if this was my loved one, I would do X, Y, or Z. I will oftentimes say, these are the resources that I know of that we can help to try to offset the cost or what they look like. I'm here to inform you about the decisions and give you as much information as you can to make the decision possible. Or I'll say something along the lines of, I'm here to walk with you through this journey in health to decide what's best for you. I'm not here to decide if you need chemotherapy, if you have to do the CT scan. And then oftentimes it's hard. We went to med school, we went to residency. I've been practicing for 15 years. I've had a lot of time doing this, and I have a patient who's hurting and scared and being thrown all these massive decisions in a short period of time, and it can be really hard for them to know how to do it. So I'll oftentimes throw something in. If you were my sister or you were my mother or you were my husband, my recommendation would be X, Y, or Z, but that's based on what I know of their priorities, and I'm just getting to know you, and I don't know your priorities.
I'll throw one more curve in there. I had a doctor that I worked with in an ER in California who I really respected, really loved him. When I came onto the shift and he was working, I was like, it's going to be a great shift. He got sued. He got sued for missing a cauda equina, which is like spinal cord injury, and it's like one of those things like never miss. Anyway, long story longer, he became somebody who ordered
Unnecessary.
MRIs all the time. And an excellent doctor. I think anyone could have missed that case. You know what I mean? You see a certain number of patients in your lifetime, you're going to miss a diagnosis. Do you see the litigious nature of our culture and about people being able to sue for enormous amounts of money for an honest mistake? Like, how does that factor into the cost of healthcare in our country.
It's huge. And there's been estimates and studies that I think way underestimate it. Because I think just like you're saying, it impacts us both consciously after someone gets sued like that, but I also think it impacts us unconsciously in all sorts of ways that we order tests.
Forever after.
Early, yeah, or even early in your training, or you hear of someone else's case.
Right.
Or you hear that the hospital lawyer says X, Y, or Z. And so it's easy to stray from the data and the literature in order to ensure that you aren't missing anything. But I think what patients don't oftentimes understand is that by doing more tests, we actually cause harm. And so there's data to show that if you give people special care, you do more tests, we're going to find more things, and that there are consequences of finding incidental things. You might find a mass and you go to remove it, and their lung collapses, and then they're hospitalized and they get a pneumonia. There are consequences to every medicine, every procedure, everything that we look for. And it's a risk balance of how far do you look and what do you do? And I think we have an expectation that healthcare workers are not human, that they are infallible, that medicine has become extraordinary in so many ways. But the number of patients I see in the ER who say, I can't be sick, doc, you need to give me something so I'm not sick. Or I had a 75-year-old the other day who said, I'm just not as fast and agile as I used to be in my 30s. Can you help me figure that out? And I was like, you're in your 70s. Like, life happens. We do all get older, and I don't want to miss something, but we also need to realize we all die. Sickness is real. Viruses, bacteria, infections are a constant threat that we're always battling. And so that space is always there. So I think as patients, we don't have really clear expectations of illness and sickness. And we have these mass expectations of healthcare. I heard a great line about when I can't find something wrong in a patient, I say, medicine and science just hasn't caught up with your disease yet. We just don't have the answers. But I hear that you're struggling. I just don't have the answers because our understanding hasn't gotten to that point yet. But I think that the role of malpractice is astronomical to our healthcare costs. Also, people not willing to practice in rural communities, to listen to what patients want, to listening to advanced directives, to this tension between we see healthcare providers. And I think that it's getting worse. I actually believe that post-COVID, the tension between, I think, the general public and healthcare became greater during this tension between what we would see, what was happening in the hospital with patients dying everywhere around us, super sick, and the community saying, I'm not seeing what you're seeing. Everyone around me is fine. I don't know what you're talking about. And seeing what we saw, there's this increasing mistrust between the two. And so I think providers and physicians have in some ways said, fine, I'm just going to do what I need to do to protect myself and move forward. And so I see increasing defensive medicine practice. And that makes me concerned because I don't think that does patients well. And I think it costs us more.
I'm really glad that you brought up the point that more testing can lead to more harm, because I think for the average person who walks, who doesn't think about their health that much, they think that extra tests is better care. And if I had a dime for every time I had to explain that ordering a test that's not going to change what I'm going to do today is an unnecessary test. Like that, it may be interesting for you to know why such and such is happening, but I'm still going to prescribe this same medication.
And it's not that you don't want the best for your patient, or it's not that it's about the cost of care, even in that individual decision. It's that we can really do harm by doing too many tests. I also think that there's this perception that tests equal health. I had a patient the other day who had an ear infection, and she said, can't you do some tests to show that I'm otherwise okay? And I always say in the emergency department, I'm there for 3 different differentials. What's the thing that's going to kill you? What's the thing that's most likely? And what are you most worried about? And so I just sat there with her and I went through all 3. And I'm like, what are you worried about? You're worried about something I'm missing because I can see an ear infection. I'm telling you how to treat the ear infection. I'm giving you the resources, but you still are worried about something else. It turns out that a family member had died of cancer a few years ago. And so she was really worried that she could have that same cancer, and she wanted these tests. The test wouldn't have shown that at all. But we talked about what screening she can do, what lifestyle modifications she can do to minimize that risk. And she left satisfied and happy without any tests. But we are not incentivized in the healthcare system to have that conversation in the same sort of way. And it's easier to oftentimes just do the tests, but we do harm. CT scans are the one I think about all the time. Little kiddo comes in and hits their head. There is such good data on who we should scan and who we shouldn't scan.
I have a story on that. I had a kid who fell off the back of a tractor and was like maybe 2.5 years old. And the physician that I was working with that day in the ER was like, yeah, you're not scanning that kid. And I kept going back and checking over and over again. And there was just no consoling the child. 2 hours later, no consoling the child. Made the doctor go see. He was like, yeah, let's get the CT scan. We got the CT scan. There was a small bleed. What did we do? Nothing. We observed for 48 hours. So it turned into a hospital admission. There was no procedures performed. It was repeat imaging. It was just like, in a way, it was, again, if you really focus on what happened because of that imaging, really nothing.
No, 100%. And that's why we need to continue to have data. That's why we need to have good data systems to be able to look at it and say who needs imaging and who doesn't. And then good clinicians who can sit down with patients and say, your kid's inconsolable. I'm worried about your kiddo. We can observe them. We can do these things. But the data shows that
even if
they have a head bleed, that
we're probably not going to drill a hole.
And the ability to potentially admit the kid if they don't have the social support at home to watch them in case things changed or got worse. Or that is where I have loved working in Alaska. And I think that Alaska really offers not only the country, but the world the opportunity to see health solutions that other people can't see in the same sort of way. So when I was training in residency, if you had an intracranial hemorrhage, even if it was tiny, you got admitted to the ICU. We had a patient who was pregnant. There was concern on her head CT that she had one. They wanted to get an MRI. She went to the MRI and her placenta essentially ripped off of her uterus and she was bleeding to death. Ran to the OR, barely saved the baby and the mom. It was a crazy case. All to determine not anything that would have changed this patient's outcome, which place she needed to be placed in the hospital because of a protocol that was there. Fast forward to moving up to Alaska, we have these head trauma guideline protocols that look at outcomes, even for small, little, tiny subdural bleeds, to say which ones really need a neurosurgeon and which don't. And so many communities keep small head bleeds that in a tertiary committee center would be admitted to an ICU, not because the ICU is better care, but that's just the protocol. And we've never stopped to ask what really makes sense for the patient. So I think actually our cost as well as our time and distance force us to think about solutions in different ways. They also force us to find solutions that are community-based and whole person centric. So when we were talking about the cost of healthcare as well as the outcomes, I think the other thing we always have to consider is like the lifestyles in which we lead, which lead to cost and more outcomes as well. And one of the things, again, that I love about living in Alaska is that the person and the place and the community are so integrated that thinking about all of those things together from a solution-oriented standpoint, like our head protocols, are now used amongst many rural states in the country. That's an example of where we really led the country, and now we see other states adopting, where we've been able to look at the data and say what really makes sense for patients. And I think there's a lot more we can do in that space.
So our conversation today, we never really made it to you going to work in the Dunleavy administration. But I guess just to round it out, thinking from your perspective of having been the chief medical officer for the state of Alaska for years, thank you for your service. What are strategies at the state level for improving outcomes and lowering costs? Where do you cut costs? Everybody thinks they need more money.
It's incredibly challenging. Healthcare is incredibly complex. I am a simple person and I like to break it down. And for me, that's been really helpful. And I've mentioned a couple guiding principles I've had, like always showing up for the client. Another one was an attending of mine early in residency. We had this awful case. There was a lot of questioning the case. The patient ended up doing well. But he said, Anne, you always have to do what's right for the patient and remember that the rest is noise. And I think in healthcare, it's so easy to get sucked into all this noise that it can be really overwhelming. So I think for me, when I think about our systems and systems of care, for number one, it's like what's right for the patient and then what's noise. When I think about how we can build systems that better serve patients, I think of 3 different buckets. Like what is our role? How do we share between roles to be able to move forward? And how do we put the patient in charge of their health? Like how do we do those different things? And I think to have any meaningful change in healthcare, you have to involve 5 different groups. I think you have to involve providers. You have to directly involve patients. You have to involve policymakers. You have to involve the public, like the Matsu Opioid Task Force. And you have to involve communication, press, blogs, podcasts, that space. And I think to have meaningful change, you have to involve all of those. I think you need data to be able to make data-informed decisions. And that's why, again, I've become more and more focused on making sure that we have readily available, de-identified, system-level data that allows us to make decisions to be able to improve health and health outcomes. Otherwise, the legislator wants to me, everyone's got a story about healthcare. I was like, that is true. Everyone has interacted with the healthcare system at one point or another, and everyone has a perspective on how to fix it. And those are all important perspectives, but to change the system in a meaningful, sustainable way, we have to have the data to know where those places goes. And so I think there's a ton of work that we can do in those directions.
Do you think we have adequate data right now?
No, we're not even close to it. No, I don't think we do at the federal level. I don't think we have at the state level. I don't think we have at the local level. No, 100% no.
So step one would be to improve the data collection and basically get more data.
Yeah, I think that there's been a lot of conversations with it. We talked a little bit about the healthcare costs and the data of what people charge. That's one thing. The state has in statute the Health Information Exchange. And I know you were at the meeting recently, but that was really made as an opportunity to share. It's not required in the state. Some states it's required. It also has limited authority for sharing information on a population health perspective and a public health perspective. So if we want to better understand the number of syphilis cases that have gone untreated, that is a tool and resource that could do it. It wouldn't have to be that Joe Schmo has syphilis, but it'd be like, we've had this many cases that have been able to do there. And then a provider who is directly caring for that patient could see if that patient had ever had syphilis or not. So there is huge ways to have de-identified data to be able to do it. So I think that there's some legislative changes that could make those things much smoother and happen.
I'm just going to guess from having attended that conference that you're going to get pushback. One of the pushbacks that came was from the
tribes
and THC.
Yeah.
That there's a history of misusing tribal health information data, of saying that you're going to use it for one thing, but then using it for other things. And so there's this justified distrust in doing that. And I raised my hand at that point because I said that it's something that comes up a lot, is that I just want to know what people's medications are. If I had a dime for every time somebody says that they're on like 8 medications, they can remember 4 of them.
2 white pills.
Yeah. And honestly, I need to look at the medication list to have an idea of what their medical problems are, because a lot of patients don't even know why they take a medicine. They don't know what the medicine's for. I don't know if people understand how hard it is to provide decent medical care to patients who don't know what their medical history is and don't even know what medications they took today. I want to see that. If we just had a PDF file for this patient that just had an up-to-date medication list, it would be life-changing. And I asked them, I was like, look, I have a lot of patients from ANTHC who would go to urgent care on a Friday night instead of going there. And I don't know what they're taking.
I think that there's huge pushback to data, and there has been, and I think rightfully so, and will always continue to be so. And I really invite the conversation and the discussion. I honestly think about it similar to roads. There is real risk in me driving here today. Like, I could get in a car accident. There is risk associated with it. And we have system-wide ways that we have checks and balances on speed limits. We invest in things on the road structure so that I didn't just come through the mountains on my own, but I took the road into here. And there's personal responsibility in what that space looks like. And I think we need to think of data in a similar sort of way. How can you own and manage your own data so you can share it when you want to and how you want to with who you want it to? And what ways can we have systems that allow you to do that? The most heartbreaking one for me all the time is a patient who comes in because their heart has stopped at home. EMS gets them back and they come into the emergency department. And I have no record of what this patient's wishes are. And if we do CPR, we are breaking their ribs. We are putting a breathing tube down. We are in many ways torturing this patient and going against their will if they had a do not resuscitate information in their chart. But if I can't see that, I can't act upon that to be able to respect those patients' wishes. So I really think this is about data democratization and allowing individuals to have autonomy and sovereignty over their own health. You're right. Patients look at me all the time and they say, well, you should see in your computery thing what's in there. I'm like, this is a fancy billing device and it actually tells me nothing about your history.
Or my favorite is, I've been here before. So I'm like, oh, okay, great. And I go back and no, you didn't know what your medications were the
Then.
last time you were here either.
Yeah. It
So-
constantly happens. And that's why part of the reason I encourage patients to put on their iPhone and the medical information what their wishes are or who they want us to contact, like taking ownership of it for them. It's part of the reason the state went with this app called Docket so that you could see your immunization record so that you could pull it up every day in the emergency department. I'm like, to get the information for me and let me know if you're immunized, and I'll help to make a decision if you are or are not there. So I don't think this is about the state having data. I don't think this is about big government having data. This is about data democratization and making sure patients have their data in their hands to share with who they want to and when they want to. And we have the technology to do that. The GPS on my phone doesn't drive my car. I can turn it on and it can tell me where to go. And we need to increasingly give patients the authority and autonomy to have the rights to their own data and to share it how they want.
That's a really cool idea.
It's their data. Patients ask me all the time, can I have my labs? I'm like, you made that CBC. I didn't make your hemoglobin. Your body built each one of those red blood cells. Of course you can have your data.
And some people are technically savvy and can pull up their labs on their phone.
Yes, and that increasingly it's becoming available. And there is actually federal legislation now that makes it so hospitals have to make it digitally available to there. So I think that is a step in the right direction and is getting more and more. And again, phones and other things are really leaning into watches. I can't tell you how many arrhythmias I have seen because a watch has detected something and the patient comes in for it. That is data democratization. That is that patient to be able to do it. But then being able to allow me to see what that is and having me send that to cardiology is the next step to be able to do that. Or sharing your images from your CT scan with the orthopedic surgeon who's going to be able to do it.
So they don't need to get some more up-to-date images, whatever they justify to repeat something that you had done a week ago.
And then there's ways that we can have quality metrics on top of it. If you already had the imaging and you repeat the imaging, we're not going to pay for that second imaging. Those are the ways that I think then you can layer on components of it. And I also think when I started that HUMS program at Matsu, on average, each patient we saw had 6 different case coordinators working with the patient. None of them knew each other. And so part of that system was to try to create an IT system so that the case coordinators could work together and see who was the primary, what were those meds, particularly for those complex patients. And just that visualization of where patients were getting their care and what was happening allows physicians to go from judging a patient to acting on data-driven decisions.
Now that you're no longer Chief Medical Officer for the state of Alaska, what are you doing?
It's a great question. Right now I'm working shifts. So I worked last night. I was on a biosecurity meeting earlier this morning and then meeting with you. So I'm working that. And
how much sleep did you get last night? Or how much sleep have you had from your shift last night till you saw me today?
Last night was a short night. Last night was 3 hours. But I'm a big advocate of sleep. So I'm an 8-hour person in general, but I think of it a little bit more like a bingo card. I try to get it where I can. So I'm still involved in some sorts of policy things from that perspective. But I have one daughter who's off to college and my other's only got 2 years left. And as I mentioned earlier in the podcast, family, they need me. They had love when they were little and they need me and my husband when they're older. And so that's my priority for the next 2 years. I love systems work. I love being involved in these things, but they're my priority right now.
And last question, if folks listening want to learn more about healthcare in America, healthcare in Alaska, is there any place that you recommend they go?
Oh, that's a great question. There used to be more forums on healthcare that I felt was having honest, really good conversations. There's good meetings that happen on a regular basis. The APOD meeting and the State of Reform meeting and other ones, people do come together. I think reading about it, not assuming and asking questions. I was on this great biosecurity health preparedness meeting and they said, I just wish those darn public health people would shadow us in the emergency department for once. And a bunch of my public health team came and shadowed a bunch of people in the hospital and saw what life was like there and vice versa. So I think honestly, just putting ourselves in other people's shoes is the single best way we can learn about healthcare. But I am hopeful that we can start to have more meaningful conversations about what's next in Alaska for healthcare. I think there have been a lot of systems that have needed to get up to date as a state. There has been efforts in the past, and I think we're starting to get ready to be able to make some really meaningful change that can not only be revolutionary for our state, but for the country. And I feel like the national and tribal sovereignty in this state is one of our greatest assets. I think there's so many things that we have to learn from the tribal healthcare system and from tribal sovereignty. We all want sovereignty over our health. We all want to be able to make decisions as a community, as location-based, in the community that we live and work and play. And I think we've got a lot of things to learn from their system. And I think if Alaska learns from and partners with our tribal system, we have amazing opportunities to have a really amazing, healthy state.
Dr. Ann Zink, thank you so much for being on the show today.
Yeah, thank you. Thanks for having me.
Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@akleg.gov or call my office at 907-269-0123.